Thanks for our listeners, and I see some of the friends from organizations like Lung Care Foundation, even Life, Economic Times, and a couple of others are there. So thanks very much for attending. This session will be recorded, so if there is you can refer to it later, especially journalists who will join the discussion. And I also wanted to say that anything that the speakers will say is on record, uh, and journalists will be free to file. So in case you're making a statement, then please keep that in mind. However, I will request anybody from media who is filing a news story to please check back with the experts on what their quotes are. Before I proceed, I wanted to welcome all our panelists here. I will avoid very long introductions, but the eminent panel does need acknowledgement, and I want to welcome each one of you quickly. Dr. Saha, who everybody knows was the former additional director of CPCB and still is invested and passionate about air quality issues and makes his contribution, like he said. Thanks very much for joining us, Dr. Saha. Shagnik, who everybody knows is at the helm of affairs when it comes to air pollution research at IIT Delhi, and he's also the coordinator of Center of Excellence for Research on Clean Air. And Dr. Shagnik Dey is an associate professor at IIT Delhi. We have Dr. Abhijit Chatterjee, who's an associate professor in the Department of Environmental Sciences at the Bose Institute, and also part of the National Clean Air Program of the MOEF. And we'd like to hear from you, Dr. Chatterjee, on what the progress is under the NCAP, especially with respect to the state. Dr. Manas Ranjan Ray, one of the early campaigners who talked about health in the context of air pollution, and from the National Cancer Institute, we've relied on Dr. Ray's advice and guidance several times as we've tried to bring our own thoughts together on what to do on air pollution impacts with respect to public health. And thanks very much, sir, for joining us. We also have Professor Arun Sharma, who has been quite instrumental in working with us in the last year or so to help us shape the discussion on health and air pollution. Dr. Sharma is the director professor in the Department of Community Medicine at University College of Medical Sciences, and has also been doing some citizen science projects as part of the Society for Indoor Air that he chairs. Welcome to you, sir, and thanks for joining us. We have Dr. Madhumita Dobe, who's the director professor in the Department of Health Promotion and Education at the All India Institute of Hygiene and Public Health in West Bengal. We haven't met Dr. Madhumita, but very pleased to meet you here and look forward to hearing from you. I am not sure if Dr. Gautam Ghosh has joined us. He's a pediatric pulmonologist with the B.R. Singh Hospital in Calcutta, and also has been part of the IAP's respiratory chapters. Quite an eminent panel here who will talk about what we wanted to discuss today. And let me explain a little bit of what that is. Typically, like I said, we are not a primary research or a technical research organization. However, we are playing the role of a facilitator, which is why we split this session into two parts. In the first part, we wanted to discuss the air pollution trends, the hotspots that exist in the state of West Bengal, what are the key considerations for the Clean Air Action Plan, and what is the status of air pollution in the state. And in the second part, we wanted to discuss what is the available data on public health. And we also wanted to hear from the panelists on how to bring the gaps in the data in such a way that we are able to address some of those gaps. And like some of you always say in several panels that we have always heard you say, that health is fundamental to why anybody and in the country is really going after even the air quality management program. And some of us have worked in many other states, even for instance Delhi, where the decibel level is very high and there is a high degree of political attention, even if the actual actions being taken are still debatable, but at least the issue is very high in the political attention. And it isn't coincidental that ahead of West Bengal elections, we wanted to just test out that narrative as well, that while the state is going into elections and many other issues are taking precedence, is there a way to also talk about air quality as one of the determinants on how people see which party should come to power? It's a long way away. I'm pretty clear at the moment that air quality, public health are really not those issues which decide voting behavior in a country like ours, but no harm in testing the waters, especially in a crucial state like West Bengal, which has about 7 cities in the National Clean Air Program, which are the non-attainment cities. And a lot has been said about Calcutta and now Greater Calcutta region, but I think there are more things that you all will be able to talk about the state itself and some of the other cities. Without much ado, I will just explain what we will do now. First, I will invite Shagnik to just lay the context and talk a little bit on what are the main considerations for going ahead on the progress of the Clean Air Plan and what is the mapping for the state of West Bengal. After Shagnik's presentation, we will do a small discussion between Shagnik, Dr. Saha, and Dr. Chatterjee. And at that moment, we'll open the floor for a bigger round and also involving our health experts in the second round. I will pause right now, and Shagnik, I would very much like you to set the context for considerations of our discussion today.
Yeah, thanks, Aarti. Can you all see my screen?
It is working, yes. You might want to do present mode.
Yeah, sure. Sorry. Yeah, thank you for inviting me for this exciting panel discussion. And I'm pretty much happy that we have actually people joining from the medical side. Because often in air pollution dialogue, we always see it's just the air pollution exposure people who are actually do all the talking. So what I will do is that in the next 10 minutes or so, I will try to give you a sense about what are the important considerations by which we should prioritize the Clean Air Action Plan, particularly in the context of West Bengal. However, I will mostly draw examples for our from our national level analysis. So recently we produced this national PM 2.5 database at 1 kilometer by 1 kilometer resolution. For more than 20 years of data, you can see 2000 to 2019. This is a kind of a hybrid data where we use satellite data model and then integrated with the ground-based measurements. So the reason I'm showing this here is that if you focus, first of all, obviously we know that the key pollution problem lies in the Indo-Gangetic Plain states, all the way from Punjab to West Bengal. Although I am showing just for India, but Pakistan and Bangladesh also actually fall within this range. And particularly now, if you focus on West Bengal, you will see that based on the 20 plus years of data, and if we take the Indian national standard 40 microgram per meter cube, then one can conclude that the entire state of West Bengal is actually non-attainment. As per the NCAP, obviously, the non-attainment definition is based on the ground-based reference grade monitoring, where either PM10 or PM 2.5 is being measured, and West Bengal has 7 non-attainment cities identified. But the main point I'm trying to say is that the entire state is having pollution level more than 40 microgram per meter cube. That's number 1 point. Number 2, when you look into the long-term trends over the 20-year period, you notice that the trend is in fact higher over states like Jharkhand, Gangetic part of the West Bengal, Orissa, and if you follow also, this particular region, so this is actually higher than what we observe over the Delhi and these regions. So although the overall pollution level is slightly lower in West Bengal compared to Delhi and surrounding NCR regions, but the rate of increase is much higher than those regions. So that's number 2 point. And then once you zoom into the West Bengal state, we find that the 2 key regions are the Greater Kolkata metropolitan area and also this Asansol Durgapur industrial belt. Just to give you some numbers, so the state population weighted average PM 2.5 exposure was 66.6 in 2001, and it increased to 78.2. And you can see that both in urban and rural population, almost comparable increase in the exposure level. And this is again important from health perspective. So if I just quickly move, then West Bengal being situated at the end of the Gangetic Plain, it ends up actually receiving the pollution backlash from the western part of the Gangetic Plain. So what this map here shows is a kind of a seasonal anomaly. So previously I have shown the annual concentration. So here, based on the annual concentration, if you look into the anomaly, you can see that obviously in monsoon things get clear. Even in pre-monsoon also, you can see that West Bengal, the pollution level significantly decreases. So it's mostly October to February. And particularly in October and November, the pollution stays more in the western part of the Gangetic Plain, and slowly meteorology pushes this pollution back towards the eastern part of the Gangetic Plain. So if you focus on the winter season, December, January, February, you can see that the entire pollution is sort of pushed back towards West Bengal, because that's the only way to flush the pollution out to the ocean. So that means the pollution in West Bengal is not just affected by the local emissions, but there is also a very large impact of the regional transport. If you also look into the seasonal trends, uh, you notice that in West Bengal, almost 3 seasons, we observe the increasing trend. Now, based on this kind of data set, what we have done is actually we have tried to identify regional air states for the entire country. And again, this is telling us the same story. For example, in December, January, February, you can see this entire region belongs to one particular air state. And this is a massive regional air state. Meteorology controls the movement of the pollutions back and forth. March, April, May is slightly different because the meteorology changes. So West Bengal belongs to an air state, regional air state, where actually you can see that Jharkhand and part of the Odisha is also coming. And again, things change during the other seasons. So main message from this particular side is again, that we need to take regional approach. Also, what we have found is that there is a very strong diurnal amplitude in the exposure level. Again, important from the health perspective. So this map here shows what is the diurnal amplitude in the PM 2.5 exposure in different seasons. And you can again see that particularly in October to February, maximum diurnal variation in the exposure is observed over West Bengal. Another interesting point what we have noticed is that if you look into one meteorology which influences PM 2.5, that is the planetary boundary layer height, that sort of shows a decreasing trend over the last 18, 19 years, more so over this Delhi NCR Punjab region than West Bengal. What does it mean? It means that although the mixing layer height does not decrease faster rate compared to Delhi, but if you recall that beginning I have shown that this region shows a higher rate of pollution increase. So it clearly means that emission impact is stronger than the meteorological impact, particularly in West Bengal, if we talk about the rising PM 2.5 trend. And what we also notice is that in the last decade, that is 2010 to 19, there is a larger rise in PM 2.5 compared to the previous decade. In fact, in this particular decade, it was mostly the Kolkata and surrounding area, and to some extent, Haldia and these regions where PM 2.5 has significantly increased. However, and to some extent in the Asansol Durgapur corridor, but now you see this entire Gangetic West Bengal, there is a massive increase. Now, whether this is, how much of this actually is due to regional transport versus local emission needs to be understood. Since there is a very large data gap, we started actually deploying some portable sensors. We are setting up a calibration protocol, and I came to know that West Bengal Pollution Control Board is already engaged in actually covering up the entire state with such kind of sensors, which is a welcome step. So with this kind of data, what we can do is that we can develop very high resolution information. And also this figure shows the correlation coefficient between the central is actually Kolkata, and it's tried to understand what is the impact or regional sort of city or state where the correlation between the pollution level is high. And you can clearly see that for Kolkata, typically this is the region which is important. But the point I'm trying to make here again is that So many sensors being deployed, satellite data now being significantly used, and now reference grid monitoring has also improved. What we should do in future for West Bengal is generate this sort of map which we did for Delhi. So in Delhi, what we did is that because Delhi has a fair good amount of measurements, so we have developed a machine learning based algorithm, and now we are mapping pollution level at 100-meter by 100-meter resolution. So this scatter plot shows how good is the model compared with the measurement. But the most important thing is that once you have such finer resolution information, you can actually then extract the information at ward by ward level. So for example, in Delhi, you can now identify which is the most polluted ward, which is the least polluted ward, what is the basic difference, but you can actually see that there is very, very high spatial heterogeneity, and we are now trying to understand what is actually causing this very large spatial heterogeneity. And this is exactly what I'm planning also to do for West Bengal cities. Now I'm switching gear, and I will talk actually about some of the recent works which my group is doing. One is the time series study in Delhi, where we are trying to understand the impact of short-term exposure to PM 2.5 level and its composition on all-cause non-trauma mortality. And this figure particularly shows what is the percent excess risk when your pollution level increases to the next interquartile range. There are three colors. One is actually the cumulative impact for the 6 day, then lag 0 and lag 1. Now, I want to draw your attention on one and particular important point, that when you do this analysis with different species, what clearly emerges is that some species is showing very high impact. For example, you can see there is elemental carbon or black carbon, chlorine, secondary precursor ions like ammonium and nitrate. In fact, similar impact was observed when we actually converted them to ammonium nitrate and ammonium sulfate, and then organic carbon. So clearly what it tells us is that we need to move beyond PM mass. And we cannot talk about just PM ever devising. And the last point I'm trying to say is that another cross-sectional analysis which my group is doing, here we are looking actually the chronic exposure impact, on anemia prevalence amongst the women in India. All of you know that in India has very high proportion of anemia. So what we have found is that 1 microgram per meter cube increase in PM 2.5, and for this actually we use the National Family Health Survey data and our satellite-based exposure data. So look at this table. It's very clear that the impact on anemia for 1 microgram per meter cube increase in PM 2.5 level is 0.75%. Now, if you talk about black carbon or organic carbon or sulfate, these impacts are many-fold higher. And again, very clearly it establishes the importance of studying PM 2.5 composition. So last slide, I want to end my talk saying that these are the key considerations I believe for mitigation plan, not just in West Bengal, but anywhere in India. We need to identify air shades for the urban agglomerations. Currently, we are not doing that. We are entirely focused on just the city boundary, because the National Clean Air Program is focused on the non-attainment cities. All the studies, mostly the emission inventory and everything is happening within the city. Also, what is not happening is that the emission estimates, they are not updated periodically. In India, whenever we talk about air pollution, some new study, it starts from scratch or uses some old emission data, but it is done at an interval of 5 years, 6 years. By the time we do this kind of assessment, emission patterns have changed. So what we need to do is that we need to develop a framework where emission can be updated annually. And then what we need to do is that we need to establish the source profile at a regional scale. Because clearly, as I showed, that entire West Bengal pollution level is high. So you cannot clean Kolkata, you cannot clean Asansol, we cannot clean Haldia or any non-attainment city just doing something within the city boundary. And also, as I mentioned, we need to focus on the secondary precursors and particularly on the carbonaceous aerosols. I'm sure Abhijit will also talk about more on this issue. And since we have a health panelist, I think it is very important that we need to establish a framework so that we can link actually the mitigation measures to the expected health benefit. Again, this is not happening. And finally, also what is not happening is prioritizing action based on the cost effectiveness of the measures, because everyone is having a wish list. We cannot really target every source, every sector simultaneously. We need to prioritize them. And in my opinion, the best way to prioritize is assessing the cost effectiveness of the measures, which again, we are doing actually as part of a World Bank study. So I will just stop here. Okay, so this is my way forward. I think we need to do epidemiological studies, particularly focusing on West Bengal in more recent years, because we have the exposure data, and I will be very happy to collaborate with the medical fraternity if to do more studies, in particularly in the West Bengal. This is very important. We need to identify the counterfactual exposure level for the state. We cannot rely on the WHO air quality guideline. As I mentioned, that dust has much lower impact on health compared to many other anthropogenic particles. So it is impossible for India to meet WHO air quality guideline of 10 microgram per meter cube when we have so much background dust. And obviously, we need to create a source tag PM composition database for the state, which we are actually, we have undertaken, and hopefully in next year or two, we should be able to do that. Thank you very much. I will stop my presentation here.
Thanks, Shagnik. I think you really have explained quite a bit, which now basically you, Dr. Shaha and Dr. Chatterjee should talk a little bit about, because the points that you made about how the long-term trends are higher in states like Jharkhand, Orissa, West Bengal, especially because some of the participants here are also colleagues who are working with the Delhi focus. I think it is important to bring that point home, that it's not just Delhi which has the worst air quality. Of course, it has been said before, but the way you presented, which shows that the rate of increase is much higher in these states as compared to Delhi, certainly is a point from looking at it from a national point of view with respect to air quality. But for this session, let's zoom in back into West Bengal, and maybe first I invite Dr. Chatterjee to share his view on what do you think, sir? I mean, you're part of the National Clean Air Program. In a way, that's the only policy instrument that we have to work on clean air. And what Shagnik is saying is both, important, but at the same time, it feels like it's a lot more than what is actually being done. So could you talk a little bit about what is actually being done?
Yeah, before that, I just want to extend what Shagnik ended there, that we know that the best way to reduce the air pollution is controlling the emission at the sources. Okay. Now, about the sources, am I audible?
Yes, of course. Please keep going on.
Yeah. So about the sources, as I said that all the sources are well known to all of us. Okay, so since very long past, like vehicular emissions or domestic cooking, industrial emission, roadside littering, whatever. So then why are we meeting today? Okay. So the thing is, if we keep on studying, focusing on the PM 2.5 as a whole, what Shagnik said, okay, so it actually doesn't make sense at all. That I can assure you. If we talk about the PM 2.5 or PM 10 or any other, air pollutants as a whole, so we actually, this kind of study doesn't make sense in terms of mitigation of air pollution. Why? Because there are several studies by my group, and some ongoing studies are also there, that we have observed several events in Kolkata where PM 2.5 level is well below the national air quality standard, that is 40 microgram per meter cube. There are several events in a year. But if we go for the chemical analysis, the components of the PM 2.5 aerosol, you can see that the huge amount of elemental carbon or black carbon is present, or any other toxic elements are there within the PM 2.5 mass, which is as a whole below the national air quality standard. So, for example, 35 microgram per meter cube of PM 2.5 concentrations for a particular day, for a given day. So you can say that, well, it's a good is a below air quality standard, so well below the national ambient air quality standard, so it's a good air quality. But if you look into the into the PM 2.5, you can get that is a large amount of black carbon or elemental carbon present over there. So it's kind of misinterpretation. Okay, so unless you go for a good and the proper chemical speciations. So for that, to do this, what you need to do is to choose a good source receptor modeling. If you do not choose a good source receptor modeling with a large enough and a good number of database, the entire statistical state, the test would be insignificant. So you will get some values, you will get, some values, in terms of the concentrations or the sources, the contribution of the sources, but this would be wrong. Okay, so even from the health perspective, Sagnik will definitely agree with me that one-to-one correlation between the total PM 2.5 mass and the rate of the mortality or the number of mortality, that actually doesn't make sense. If you correlate the amount or the concentrations or the level of the toxic elements, whatever it's a heavy metals or ions or some elemental carbonaceous compounds or organic carbonaceous compounds with the rate of mortality, then it would much better make sense. Okay, so what we need to choose a good source apportionment model in true sense. Otherwise, the contributions, quantitative contributions of the sources, that would be underestimated or overestimated. So good quantitative contribution and choosing the good model is the first thing. Now, as Sagnik said, that Kolkata, if you look at the geographical positions of Kolkata, so it's at the most lowest part of the Indo-Gangetic plain. And not only it receives the air pollutants transported from the Indo-Gangetic plain, but also from the Nepal itself, which is mostly unaddressed in most of the studies. Nepal is a very good contributor, mostly in the season of post-monsoon. A huge amount of pollutants are transported from Nepal itself, and also from the other northeastern part of India because of these jhum cultivations, the massive biomass burning. And one of my recent studies have also shown that during summer, though the concentration level of PM 2.5 and the other air pollutants are very low during the summer because of the high convections and the high temperature, whatever, but a good amount of pollutants are also transported from the Eastern Ghat region. So this is also kind of the shifting cultivation, where the tribal people in Andhra Pradesh, Karnataka, Jharkhand, not Jharkhand, the southern part of Jharkhand or Orissa, they burn, they slash and burn their cultivated products, the crop residue. It's called the shifting cultivation. So this produces a huge amount of aerosols, biomass burning aerosols, the pollutants which are very much carcinogenic and toxic. So they also get transported towards Kolkata. And we do not address, but which is most important, in addition to the health perspective of the people who are living in Kolkata, that is these kind of long range transport, and also from within the pollutants from within the city, it also affects the Sundarban mangrove ecosystem. So it cannot, that cannot be ruled out. So it actually affects the entire biogeochemistry and the hydrological cycle, that overall climate over this particular important part of our country or
Just
the
few
world.
pointed questions, Dr. Chatterjee,
Yeah.
if you permit. I mean, you talked about how good speciation model is
Yeah,
important.
yeah,
I think
yeah. And
the
as Sagnik showed that the relation between the anemia and the sulfate. So one thing, the chemistry plays a very vital role here, because if the sulfate is inorganic, it would not harm our health. Okay, if the sulfate is coated with some elemental compound or some organic sulfate, then it can harm our health. Okay, so what kind of sulfate it is, what kind of nitrate it is it inorganic purely, or some associated with some organic compound? So what I mean to say that the entire chemical speciations model is a very important tool and very important aspect which needs to be addressed. And as Dr. Shah is there, I just want to tell you one thing, that I have rather proposed a kind of networking project on the black carbon itself within the Kolkata city, over various stations. So that is under consideration.
Sure. I do want to ask you one question because, before I go back to Shagnik and I invite Dr. Saha, you talked about how, you need a better source apportionment, and it's not enough to just say that PM 2.5 is 40 micrograms per meter cube and the whole of the state of West Bengal is literally polluted. I think, to my very oversimplified view, it's also a question of the quality versus quantity. At least you have defined the quantity of it in terms of what Shagnik defined, and now you're asking for a better speciation model which
Right.
defines it in terms of the qualitative aspect as well. And I think we can all continue delving into the qualitative aspects of things as we go. My simple question to you is, just for our own understanding, has this been recommendation been picked up with the West Bengal Pollution Control Board, and is the knowledge network or the NCAP also mindful of this? Is that the path that they are following for the NCAP program, the kind of research that you mentioned about, or what is the view of NCAP's work in West Bengal?
I think Dr. Shah would be the best person to answer this. Dr. Shah.
Sir, your mute button is on, sir, but the
Okay.
floor is yours.
Thank you very much. Thank you very much. Good to see all my colleagues in one platform. Arati, thank you. Thank you. First of all, thanks to Professor Saglik also. I call him Saglik only. And I call all by name only. Here also I'll call by name also. Please don't mind. The thing is that first of all, the Shagnik has told that geography plays a role. So this is the point I would like to highlight and telling from many years that we cannot deny geography where we are situated, located. So Delhi is problematic because of its geology and geographical conditions. Similarly, the Calcutta is also having the similar lines. So whenever we are comparing the indicator pollutant PM 2.5 along with other metro cities of the world and Delhi, it is not justified. So that's why the methodology itself is not correct. Comparing PM2 exposure annual and ranking the cities recently, a day before yesterday they have done, I completely disagree with the methodology. And all our problems are due to the methodological problems. Shaglik has rightly told that our PM 2.5 exposure is increasing. It's not a matter of joke. I never knew this is being happening. And we are getting, right, we means now today, whatever we tell, it is in the context of West Bengal or particularly Calcutta, I would be talking. So the thing is that until and unless we understand our air quality standard is basically describes 12 basic parameters. And all state pollution control boards have to have the reports of the concentration thoroughly. They cannot just deny that we will only focus for PM 2.5. Because PM 2.5, I'll come to that point, but all other indicator pollutant PM 2.5, how much it is applicable, it is in Indian condition, it is a matter of debate. Because I personally, whenever I am discussing all these issues with the experts, the PM 2.5 cannot be an indicator pollutant for India, particularly in the Gangetic Plain. This is my personal view, and whatever the studies, chemical composition I am going through.
What should be the indicator then?
I will be coming. I will be coming. Now the applicability. We have to understand the PM 2.5. Dr. Shagnik also told. Vijit also told that PM 2.5 is a combination of various chemicals, including toxic products that are being generated across the Indo-Gangetic Plain, and in that interstate and transboundary movement, they are being carried to Calcutta and nearby areas. So The indicative pollutants, when, until and unless we understand, until and unless we understand the chemistry from wherever it is coming and what it contains, we really cannot tell this. So this is the things, because until and we have to correlate this study without on air pollution, without the study of health, it is not a complete study. Once we want to correlate the aspects of air pollution, the cocktail we heard now comes up. PM 2.5 is a cocktail. And its behaviors again depends on how much dilution accumulation is available within the environment. And Shagnik rightly said, we are mostly influenced by the meteorology. The thing is that until and unless we do it like that study, it is not complete in that aspect. So because our lungs do not understand, what is standard and what is should be given to it. Once it enters, because lungs don't have any filtration system. Whatever it comes in, it is available in the atmosphere. It gets sucked and accumulated in our lungs. And so once it is deposited in our lungs, it can be carried forwarded to various parts of the body. Again depend on what is the chemistry of that particular gas or particular air. And symptoms will be different in those aspects. So in that way, we need to correlate the aspects of the things. Now, coming to this prospect, what
Gunjan, is it only me?
No,
Dr.
sir.
Saha's sound
Yeah.
froze.
No, we
Sir,
lost.
frozen.
We lost him.
I'll give him 1 second, but from the way I heard all of you, it was mostly that few things are same, that you need to look at a regional approach, you need to look at the source profile as well. That's pretty much what Dr. Saha was saying, what Shagnik you said, and I think if I understood correctly, Dr. Chatterjee, you also just spoke of finding the quality of the PM 2.5, so to say, and not
just
just
I will just conclude in two
yes,
minutes.
Yes, please.
So whatever the study, the conventional study we are doing, whatever the source apportionment study we are doing, it is basically consists of 5 components. One is the waste part, that we are very unfair in managing our waste. We are transport, the other aspect. Third is the industry. Fourth one is the domestic, and the fifth one is our industrial part. So, and the other components we are not really dealing with is the intruded dust and the resuspended dust. These are the components of all the cities. The percentage may vary from place to place, geography to geography, activity to activity, this varies. But now, with that aspect, what type of action plan we can prepare will be a general action plan. But we need to prepare a specific action plan. Now, what should be the indicator pollutant, as Karathi I shortly and briefly said, because everything where pollution is related with burning, related with the smog formation, it is related with the formation, fume formation, etc. Everything is related to the carbon. When carbon is an indicator pollutant, that the burning is required to be controlled. Once the burning is required to be controlled, in Indian condition, I strongly feel either we should go for the elemental carbon or the black carbon, because that is required to be controlled at burning, at every combustion sources, be it in the boiler, be it in the furnace, be it in the thermal power plants, even in our kitchen, even socioeconomic condition. When the burning is the problem, that the carbon is to be striked, and because it has got climatological impact also, health impacts also, that just now Dr. Sagnik also told, and Daviti is also telling. So we must focus a focused parameter to address only burning issues to be controlled at this juncture, what I feel. Thank you.
Thanks, Dr. Saha. I know time is short, but many important things have been said, and I cannot wrap up this session, without doing a rapid fire with all of you. I think you will get one minute, because from what I understand is that you think there is a need to identify good models which can define what's the quality of the pollutant. But in any case, we are also aware that through a source apportionment, these are the 5 kind of sources that will eventually emerge. So what most of the discussion right now is about is, while we know the source apportionment roughly, we don't want to rely on it, and we want to do a specific source apportionment which gives us specific ways, or specific pollutants which we can go behind. From a very non-technical point of view, this also feels that it will consume a lot of time to do all these things, when some of the obvious things are already aware, that we adopt a regional approach, we identify the airsheds, and work on figuring out what are the priority actions. So if that is something that we want to wait out, is that my correct understanding, that we wait out till we do the source apportionment and we find out what the pollutants are, and based on that we take action? And Dr. Saha, you really did open, at least for me, another can of worms, so to speak, to say that you don't go after PM 2.5, but you go after elemental carbon, or black carbon. Of course, it feels that across India, just looking at black carbon will have its benefits, just not in terms of air pollution, also in terms of uh, the short-lived nature of black carbon, and the warming potential that it has is much more, but that has not been of attention so far. I don't know more technicality on this, but I will want to draw Shagnik in once to just give his thoughts on what the discussion has been so far. We will just do 5 minutes and we will have to wrap up this session. But Shagnik, could you take 1 minute, and I will give one minute to Dr. Chatterjee and Dr. Saha as well. But this is important to nail.
Yeah, thanks, Arti. No, I will. So all these points actually, we have been saying. The other important point in the mitigation plan, I will say, is we need to create a template or framework where emission data can be updated annually. Because if you see the entire air pollution mitigation exercise, even in Delhi, what is the latest emission data we have? We have the emission data from 2017, what the Terry report suggested, right? So it means that we are already 4 years behind. And now again, some effort is there to update the emission inventory, and that work will end in probably end of this year, and then again we'll lag. So what I'm trying to say is that in addition to all these things what we are saying, we also need to have a system where emission data can be updated. When we tried to update the emission in the Gaines model, Palak is here, she can tell our experience. So if you try to understand how much traffic emission is there in the rural areas, there is hardly any information. We do not know how many vehicles are flying in the rural areas. We do not know how much ammonia is emitted from the rural agricultural sector, because this is very important. Because if you emit ammonia, it will react and form secondary particulate. So sector by sector, what we find is that emission data are very patchy. And why it is so important? Because unless we track emissions continuously, we cannot assess the efficacy of any mitigation measures. Because any mitigation measures what we are taking, for example, power plant, vehicles and all, unless the emission data are periodic, we cannot really get a sense. So I just want to add this important point also. Thank you.
Thanks, Shagnik. I also see Dr. Gautam Ghosh has joined us. Hello, sir. Good afternoon, Dr. Ghosh. Hello. We'll come to you in a while, but first I wanted to wrap up the first discussion only. Dr. Chatterjee, you have said what you had to on the source apportionment, the need for doing all of this, how this brings together in terms of some action that must be taken in the next 1 or 2 years, considering NCAP is a 5-year program and results should come by 2030, and we are 2024, we are kind of 3 years away. What should we prioritize on?
I think other than the local sources, we need to address the regional contributions and the long range transport also. Otherwise, the entire source contributions or the source apportionment would be overestimated. What I mean to say, we need to set a limiting line for us. To what extent we can actually control the air pollutions. Otherwise, unnecessarily, we need not to be very much, so much of panic, okay? If there is 100 microgram per meter cube of PM 2.5, and if we actually know that among this 100 microgram is 70 or 80 or 65, whatever, is actually coming from the local emission sources or the local sources, then the rest 30, 20, 40% or whatever is coming from the regional sources and long range transport distant sources. So that there should be some limiting line, that to what extent we can actually control the local emission sources. So that's what I want to say, that the regional transport and the long range transport, that has to be included in addition to determining the quantitative contribution from the local sources. That's all.
Thanks, Dr. Chatterjee. I'm also reading your answer in the Q&A where you're stressing the same point, that don't overestimate the sources and find the contributions in terms of Kolkata city and set a limiting line to what extent we can actually control. Thanks for this one. Dr. Shaha, you said already what you had to, but just in terms of...
Just as one summary,
Yeah.
the regulator's duty is to see all pollutants are under control. It does not mean they should only focus only on PM 2.5 or PM 10. I'm not really in favor of doing that. Let's complete our prescription, what has been given by the regulation, that is to be completed. And the air pollution scientists must tell the impact and the speciation of that cocktail of that particular, what it contains and into toxicity, particularly the speciation, chemically speciated pollutants, and that information must be tagged with the medical practitioners and professionals, and they must tell and link with our economic loss due to the health, due to hospitalization, due to the poverty elevation, and also the climate experts can also link how it is really contributed to forcing our climate. And ultimately the sociologist must come forward to take the information to the public in general, because whatever we are doing, if it is the quality of life is not improved, nothing is doing. Thank you so much.
Thanks, Dr. Saha. I think that point is fully taken, that you find out what the constituents are and the composition is. And at least, with some of the reports we have seen, for example, if I'm mentioning it correctly, then for Delhi, IIT Kanpur did a very advanced study where they found the chemical composition of 2.5 and what it's made of. And they came out with some cutting edge research, which shows how barium is coming from Punjab and chlorine is coming from UP. And sorry, I'm missing many details, but it had like a long list of heavy metals and just, exact transport and where all it's coming from. And the study is there, the best in class technology is there, the best researchers in the country and high grade professors have worked on it, but Delhi's air pollution still remains the same. It's kind of grim, but I guess the point that I'm trying to make is that it takes something else, I feel, to shift the policy needle. We all must talk about technical studies and the best research possible, but sometimes it's also just about, for example, doctors talking about the issue with a very strong influence, and that changes the policy needle. But I think which is why we have the second panel as well. I will pause at this moment. I will open the floor if there are any comments on the first, on the technical session, and then we will move on to the health session. Please feel free to just speak into the microphone if you have any comment at the moment. If not, then I will hand over to Gunjan to begin the session on health. Okay, then we can again come back after the health session and have an open floor and do some discussion at that point.
Thank you, Aarti, and thank you so much, all the panelists. This was a very interesting discussion to see the sort of dialogue in terms of where the focus needs to be and where the science is kind of taking us. Without much ado, I think enough has already been said in terms of in terms of the pollution scenario in the state and in the country. There is, of course, this entire debate where pollution is, of course, the entire work around air pollution is based because it's at the heart of the public health issue. And I think without any further ado, I'd just like to invite Dr. Madhumita Dubey to, ma'am, if you could start with your presentation, and we can then go into further discussions about the subject.
Sure. Thank you, Gunjan.
I'm sharing your slides, ma'am.
Oh, you're doing it?
Should I? Would you like to do it yourself?
Yeah, I think I am there. Can you see these slides?
Yes, ma'am.
Okay. So good afternoon, everybody. And this is actually a wonderful learning experience for us, though we have been involved in public health. I think Professor Sharma would agree. And Dr. Ghosh I've been his junior house staff in my days of pediatrics. So a long association as well. And we've worked for years together, coming across a lot of patients with a lot of them suffering from impact of air pollution, but it has never perhaps received the type of attention which it demands. And the time is right that we start thinking about it and start thinking about it in a very systematic and approachable manner. So I'll float a few issues, and I'm sure my co-panelists and eminent scientists here would be able to give us better directions in future. So as I was given this task of rather discussing some of these points, I came across this issue in the newspaper, the Times of India, that air pollution has caused nearly 13 times the number of deaths in West Bengal than the raging COVID-19 pandemic. So that was something really, really, which is a cause of concern. And according to the December 2020 Lancet Planetary Health Report, in Bengal, obviously we don't have enough data, and there are gaps in data, and there are gaps in the way the data has been collected. There are gaps in the way the studies have been conducted. So that we'll discuss later. But then of the data we have the data that 9,712 people have died of COVID in Bengal in last year, whereas pollution has claimed more than 1 lakh of lives in 2019. And as Dr. Shah was saying, there has been association of a lot of economic loss as well. So this has all been shared, Kolkata Clean Air Campaign is a very good advocacy forum where they come out with a lot of points. And here too, you can see that life expectancy in Kolkata is dropping by 6.1 years. It's second only to Delhi. 70% of Kolkatans are suffering from respiratory disorder. But a problem here of attributing this directly to air pollution or ambient air pollution per se is that the cross-sectional studies do not allow us to do so. And I'm sure Professor Sharma would tell you later in greater details why we cannot just say that it's only due to air pollution. In order to do so, we needed to have larger cohort studies, time series studies, perhaps, and as our previous speakers have said, quantifying the exposures of different types of matter. So, but still, we do know that a lot of us are suffering from respiratory disorders. 47% are suffering from serious lower respiratory tract infection. 65% are having lung function impairment. And then 60% of motor vehicle mechanics. This is another particular vulnerable group, an occupational hazard. Motor vehicle mechanics, then these people who are in the construction industry, they do generate a lot of dust and other matter, which are pollutants as well. So they are having lung damage. 79% of street hawkers did not have good lung function tests. So 69% of the days have very poor pollution levels, and 17% are quite severe. And if you look at the 7th February edition of the newspaper, you'll see that the toxic toll is even more. So we find that we do have a lot of breathlessness. Almost 80% people have been breathless during that season, particularly when, as you said, as my earlier speakers have said, the particulate matter and the pollution levels are particularly high. Then there is cough, there is chest cold and chest ailments. then respiratory problems, phlegm, wheeze, and now coupled with COVID, this is causing a lot of problems for physicians. So these surveys, which was conducted with street vendors, the traffic police, the tea stall workers, this has shown that the overall prevalence of high-risk respiratory symptoms is a staggering 20%, which is, I think, in any standards, it's quite high. So how it affects health, we all know. We've been talking about anemia. Dr. Chaudhary has spoken about anemia. So air pollution can cause, besides respiratory ailment, it causes hematological abnormalities, impaired liver function, genetic changes, neurobehavioral problems. Dr. Ghosh is here. He'll speak in greater details perhaps, but around 65% of children are suffering from lung impairment in Kolkata, against 24% in the Sundarbans. This is a small study done by the Center for Science and Environment. Again, we've already shared the findings that 60% of motor vehicle mechanics have lung damage and 79% of roadside hawkers have abnormal lung function. So the air pollution is leading to a reduction in life expectancy in our state and in our city. Let's share some of the other reports which I came across. This is, of course, not an exhaustive list, but just an indicative list. Some 1.7 million Indians have died due to air pollution in 2019, as has been reported in the Indian report, Lancet Planetary Health, the India State-Level Disease Burden Initiative. I'm sure you all have gone through it. And there has been both good news and bad news in it. We've come across the fact that indoor or household air pollution has caused 64% lesser deaths, but ambient air pollution is not only increasing, it is also killing more. Okay. So I just tried to cull out the data of West Bengal from this report. And what we see here is overall 1.67 million deaths were attributable to air pollution. That is 18% of the total deaths were attributable to air pollution. And majority of these were from ambient particulate matter and household air pollution. So as I said, household air pollution has decreased, ambient particulate matter has increased to a whopping 115.3%, and ozone pollution has also increased. Now, how has it particularly affected West Bengal? You can see this, I'm sure all of you are familiar with this, that we are in the orange zone of population-weighted PM 2.5 exposure. We are in the orange zone of solid fuel usage as well, and of ozone concentration. So we are, if not the highest, close to the higher levels of exposure. And if you look at the cause of DALIs and deaths, then this is what is there in India as a whole, with, I think, a similar picture in every place where air pollution is occurring. We are having quite a lot of ischemic heart disease attributable to air pollution, then COPDs, chronic obstructive pulmonary disease, lower respiratory infections, neonatal disorders, stroke, diabetes, cataract, and lung cancer. So both the DALIs and deaths are quite a lot. In West Bengal, again from the same data set, what we find is that the death rate per 1 lakh population is about, I'm getting this covered. Sorry. Is 93.3. Then the number of deaths attributable to air pollution, the total number is almost close to 1 lakh. Percentage of total deaths attributable to air pollution that were in people younger than 70 years was 51 almost. Again, the numbers in every category, be it ambient particulate matter, be it household air pollution, is almost close to 40,000 or 50,000 at times. So we are having quite a lot of these effects happening. The impact is quite high. The disability adjusted life years, which means they do not die, but they do suffer from this disease so that their economic conditions also get affected. The DALI rate per 100,000 population attributable to ambient particulate matter in West Bengal in 2017 was 1434, which is quite high, more than 1,000. Similarly, to household, it was 1178, and to air pollution, it was 2710 overall. So both the data indicate to a high impact or a high level of impact. So of these total disability adjusted life years or morbidities, they are attributable to air pollution. Illnesses, we can see the largest proportions were from lower respiratory tract infections, pneumonia and others, chronic obstructive pulmonary disease, another 29%, ischemic heart disease, then followed by stroke, diabetes, lung cancer, and cataracts. So this is what the 2017 study revealed. And there were some interpretations drawn saying that if the air pollution levels had been lower than the minimum risk exposure, the average life expectancy would have been higher by 1.7 years. If the exposure to ambient particulate matter had been lower than the minimum levels, the average life expectancy would increase by 0.9 years. And if the household air pollution would have been lower than the minimum levels, it would be 0.7 years. And this, of course, the beneficial impact would have been slightly higher for the males for ambient particulate matter because they go outside more, and slightly higher for females in case of household air pollution, for obvious reasons. Let's go back to this study, which was this air pollution and human health in Calcutta, India. This was a case study, and many of you have gone through this. I think it was done in Delhi, in the Delhi School of Economics, where they did a health assessment among 100 participants with a structured questionnaire in 3 dispensaries, health dispensaries, near the ambient air quality monitoring stations operating in Kolkata with different ambient air pollution levels. And then it was found way back in 2017 only that the respiratory diseases, the prevalence being 85.1%, have far outnumbered the waterborne diseases in the patients attending that dispensary. And the respiratory diseases include acute respiratory infections, chronic obstructive pulmonary disease, upper respiratory tract infections, and influenza. So these are the common things, and this has again been corroborated by subsequent studies. The other important area, which I think now we need to put our attention or drive our attention towards, is that people know about air pollution, but lack awareness about cause and effect. We were talking about, Akshay was talking about what to do when we talk about a mitigation plan. It's not just sufficient to put in laws. It's not just sufficient to put in monitoring stations and surveillance mechanisms, but it is also absolutely essential to change the upstream determinants which are causing this, and behavior being one of the very important areas. So what did we see? That a study on perception of air quality, which was conducted by Clean Air Collective, they interviewed 5,000 people in 17 cities of India. And though the citizens knew about air pollution, but they didn't really understand about this air quality index, what you mean by particulate matter 2.5, particulate matter 10. So all that we communicate is by far not understood by them. If you look back further, in 2009, there was a joint study conducted by CNCI and West Bengal Department of Environment and CPCB. They found that 70% of people in Kolkata are suffering from respiratory disorders caused by air pollution. Other air pollution-related health problems, we've said, and we've already mentioned that these are the groups: hematological abnormalities, liver functions, genetic changes, neurobehavioral problems. Again, that were more. Some people were more vulnerable. That those are the workers who are exposed to higher levels of vehicular emission, like roadside hawkers, traffic policemen, taxi drivers, auto drivers. So this paper was also published way back in 2009, showing that vulnerabilities and risk factors do differ. Even earlier, 2006, approximately 47% of Kolkata's population suffer from lower respiratory tract infections. Okay, so the rural counterparts have less. the urban counterparts have more, and that's a well-known fact now. In 2000, we find some studies done in children where they demonstrated that children inhaling polluted air in Kolkata suffer from adverse lung reactions and genetic abnormalities. Even WHO has said that children are highly affected by air pollution. They cause respiratory diseases, cancers, and cognitive impairment. And this is perhaps the last one back in my timeline, that is 1995. It was found that an estimated 10,647 premature deaths can be attributable to air pollution in Calcutta. So my esteemed colleagues would take this discussion further, but I would like to suggest some points when we are talking about mitigation actions or plans. Now we need to look beyond just monitoring, surveillance, whatever particulate matter levels we are talking about. And we need to add to our fortifications or the agenda which we have put forward for these plans. Along with it, a very important aspect should be the aspect of improving environmental health literacy, raising public awareness of harmful environmental exposures, and empowering communities, not only just knowing, making them or facilitating their avoidance or reduction of such exposures. For that, we need effective communication with diverse audiences. What we, in terms of health education, say is risk communication in different settings. It has to be very streamlined and planned well. Secondly, we need to shift focus of policy. We've till now focused on the most polluted places, but we need to add to it the most vulnerable people as well. Large number of studies have documented that acute air pollution exposure harms human health, even in places where ambient pollution levels are generally low. But it is because of the particular work they do or particular exposures they have. So we have a traditional regulatory approach to improving air quality, which targets regions with high levels of air pollution. There is high urgency to shift the need to a new approach, targeting areas for air quality improvement based on population vulnerability rather than on air pollution levels alone. And for that, we need studies. We really need long-term studies, time series studies with good cohorts, with variable exposures, assessment of vulnerability and risk factors. I'm sure Professor Sharma will be dealing with it when he discusses these issues. So just to share how much of environmental literacy we do have, even in countries like USA, that's very poor. So although the pollution levels have been recorded as critical, only 39.3% of respondents, this is a study in USA, they said that the outdoor air pollution has affected their health. And so this understanding about air pollution and how it affects their health has to be improved. The 2017 studies, which I referred to earlier, this has revealed that more than 80% of the respondents in that study were from slums and were cooking inside the living rooms. 71% were using kerosene as the major source of fuel, 37% were using kerosene. So they are already susceptible to indoor air pollution. And on top of that, they are living in an area which has high ambient air pollution. So it's very difficult to design a proper study to get the proper results. And the current situation, if you look at the print news or whatever is going on, reporting of the health risks and precautionary measures regarding air pollution in national and regional print news is pretty poor. If you do, USA has done a recent study with the content analysis of 2 national and 2 local newspapers covering USA's most polluted regions during a 5-year period. And they found that nearly 40% of air pollution news articles are mentioning human health risks, but 10%, less than 10%, are providing information on the precautionary measures necessary to mitigate the risk. So news media reporting is also not conducive. And that's what brings me to the point that it is a multi-stakeholder issue. It cannot only be researchers, it cannot only be one sector, the health sector or the environment sector. It cannot be only the regulatory sector. All must work hand in hand. We have to provide accurate, timely information. This is very crucially needed, but it is lacking. And information actually focuses on individual risk behaviors, but it doesn't reach the most vulnerable age groups. And then again, as Dr. Chaudhary, and I think Dr. Chatterjee was also saying, that the effectiveness of existing efforts, what cost effectiveness is it giving us? How is it related? That too has to be translated in simple terms for people to be able to understand. So these are the challenges: information sources, information quality, information reach. Unless we do that and plan it out well, we will not be able to mitigate the effects. And as you can see, clean cooking has been a problem, despite the provision of a lot of different welfare programs. Now, you know, the Ujjwala program is also there. But if you consider the term enabling communities, it also involves that the community should be able to have that option and should be able to use it. Using cleaner burning technologies is not only a matter of provision, it's a matter of pricing as well. So when all these policies are also linked, in fact, recently they say India will see a 15% decline till to 2030 in the share of population relying on solid fuels, but 15% decline only. So despite the projected progress, nearly 580 million will still use solid fuels to cook, increasing their vulnerability to the already high levels of ambient air pollution, which is there outside their homes. So this is something, again, which also needs a lot of attention. I will wrap up saying that we need to let the city breathe, and we need to let the people in the city breathe. We do know, all of us are aware of what is not so right, what is going on, and what we need to change. Perhaps in the next few minutes, our discussion will give us a clearer way forward. Thank you.
Thank you so much, ma'am. This was a very enlightening presentation, and you've rightly covered a lot of ground in terms of the studies, the kind of data that is being highlighted, and what sort of morbidity and mortality rates are coming out in all these studies for India and globally in terms of air pollution health impacts. I just kind of wanted to also, because this has repeatedly come up in various discussions with health experts. I mean, when we look at data in India, there is the, especially with really like localized level data, the NFHS data is probably the closest which comes to district level health data, which is taking socioeconomic and demographic parameters into account. Often studies like the Lancet or the State of Global Air report by Health Effects Institute, or any other global studies which come out, which are pointing towards the high numbers of mortality and morbidity related due to air pollution. These often get discredited by the government in terms of with an argument that there are no Indian parameters which have been taken into consideration for the modeling, and these are foreign studies and they don't really fit the Indian kind of scenario. And there is evidently there is a gap when it comes to health data with regards to air pollution. I kind of wanted to just invite the panel, and especially Dr. Ray, maybe I can start with you, sir. If you could possibly throw some light in terms of what you perceive as the data as the gaps in data, and how you think the medical fraternity could possibly address this in terms of the quantity and the quality of data, especially with regards to air pollution as a health risk for non-communicable diseases. Dr. Ray, over to you, sir.
Thank you, Gunjan, and thank you, Dr. Madhumita, for your excellent deliberation. Now, the question that you asked and addressed to me is very serious one, and it is very important. Why? There is a lack of scientific data or the research data on health impact of air pollution in India. Now, whenever the regulatory bodies or the highest authority are going to undertake some strategy for the mitigation of the air pollution, two things, basic things are necessary. Number one is the quality data on air pollution, both spatial and temporal. That is quality. I would like to emphasize on the term quality data. And the second is the quality health data. Again, I am emphasizing on the word quality. Quality health data on the impact of air pollution of these pollutants. Okay. Now, as far as health is concerned, you know, this is a very, very tricky thing and very, very complex, because all these air pollutants which are present in PM 2.5, for example, if we add on going to their individual toxic effects, actual in reality, the scenario is entirely different. For two reasons: there may be some additive reactions, synergistic reactions, or some negative impacts between these factors or sub-factors within the 2.5 fraction. This is my own reality and understanding in my experience with all these, because we started the first health study on the impact of air pollution in Kolkata in the early 20s or in the late 90s under the sponsorship of the government of West Bengal, Department of Environment and the Pollution Control Board, the State Pollution Control Board. And that was the starting. And we think that was actually the first comprehensive study on health impact of air pollution throughout the country. And later on, we continued this study in Delhi also and some parts of northern India. So from this experience, I can say you that our policyholders or actually the policy makers, they have a bias for quality pollutant data. They are least concerned with the health data or quality health studies. It is unfairly skewed in for the air pollution data. We are mainly concerned with how much PM10 is there, how much PM2.5 is there. We rarely go for what is the impact of that concentration of PM10 or PM2.5 on the people's health. Here also, for now, the reality is that, so why this discrepancy? Why it is skewed against health data? Because, you know, for any good study, you have to have a team of researchers, okay? And that researcher should come from medicine, the medical faculty, biomedical disciplines, and also from medical statistics. We need statisticians. So these are all needed. But we have a severe lack of quality researchers in our country. This is my own reality and my own experience. We have very limited number of quality people who can undertake an epidemiological study. Why? Because now the people who are interested in environmental health research, after doing all their hard work, getting the PhD, for example, in case of non-medical scientists or their PG degree, what they will find that there is no scope for employment in this country for the people who are expert in environmental health. They are going abroad. All my students from my laboratory, at least 20 plus, they are now all settled in abroad. They are doing health study vis-a-vis air pollution, but not in India. There is no scope. All our state boards or the central boards, you go there, they are all packed with technicians, engineers, not biologists, not medical faculties. There is hardly any opportunity for job or their future research possibilities in the government sponsored, because basically science in India is governed by the government enterprises. So there is no scope. That is one point. Second part is the capacity building. Now for good quality research, we need, that is, who will actually design the study. There should be some expertise on study protocol designing. be it a short-term study or a long-term study, time series study, case control study, you name any protocol. We need some quality people to design the study. Number two, the toxicological aspect, that is who will take the samples. You need some, you have to collect some samples, be it blood, be it sputum or urine or sputum, anything else. For the buccal mucosa, this is expertise driven. So you need to develop some expertise. Who will teach you? The third part, to correlate the two, that is the air pollution level and the health impact. So this is a very tough job. You need medical statistician. Unfortunately, in our universities or in the systems, it is rarely taught. So people do not have the necessary expertise to undertake any meaningful health study vis-a-vis air pollution. This is my own realization. Now,
Right,
to
sir.
address this problem, what we did in CNCI, in the Cancer Institute, Dipankar is here. So we started quality building process to hands-on training to all the staffs of the central and the state agencies, the Pollution Control Board. It was hugely successful. We did for successive years. And our motto was that after returning to their respective states or the central agencies, they will take up of their own the health studies in their own institute or own organization. I don't know what has happened next, but ultimately this program has been discontinued. But we need all such programs in every, because we have the participant from All India's group, public health, the hygiene and public health, they can
Right.
take it. So we need quality student, we need quality job vacancies and opportunities for them. So otherwise, why people will be interested? I can make my future in molecular biology. I can go abroad. I can take any big job there. So why I will go for, and you know, health study
Right,
means
sir.
field study.
Right, Dr.
Field
Ray.
study is a very difficult one. So I think this is the main, in my opinion, these are the main problems related to why we are far behind China as far as the health is concerned vis-a-vis air pollution. You can just compare the number of quality publications from India and China on health data, that is the air pollution. Just one last point I am mentioning,
Right,
that
sir.
now we know that air pollution is intimately linked with both infectiveness and fatality with COVID-19, where the air pollution, in case of Europe, you see, North Italy is most polluted and the highest rate of COVID-19 deaths and infections are in North Italy. Same is true for UN, same is true for in Latin America, same is true for in North America. But where is the study from India? The only study that I have come across from India correlating air pollution data and COVID-19 has been published from, and the work was done from Nanjing in China. All three authors were from China, not anyone from India. This is not very good picture of our health study. Thank you very much.
Thank you so much, Dr. Ray. Some very relevant points which you've raised here. Absolutely, I mean, there's no denying that there is a gap in terms of providing support to these kind of researchers, and there is definitely, like you've highlighted, the gap in data is evident, which is why the research is also somewhere kind of lagging behind in comparison to other countries. Dr. Ghosh, if I may invite you here at this point as a practicing medical expert, if you could probably, sir, just highlight in terms of what you think is the role of the medical fraternity to kind of fill up the gaps in the data and the quality of data, and how you think that this group of people can probably be taking this forward.
Thank you for inviting me. Thank you, Madhumita, and all my seniors there. Before I say, I will definitely support Dr. Manas Ranjan there, because my two of my elder sisters are in JNU and now working in Houston on the same environmental science. And
Right.
anyway, because even in JNU the money was less, more in Houston.
Yeah.
Anyway, sorry, so I am a pediatrician, absolutely clinical. I am a fish out of water here because there are so many statisticians. So Gunjan, I will definitely pick up, and I am a pediatrician, right? I will only give 5 points and I will take 1 minute each. Is
Right,
it clear?
Dr. Ghosh.
And I
Please.
will exclusively, please allow me if I am wrong in statistics, because I am not a statistician, absolutely clinician. The first question, why children are more exposed? The children usually have 5 points. One, height is small, so the higher, more heavier particles will make more problem. They are passively exposed. In a cinema hall, they have been dragged by the families. Their activity is more. They inhale more pollutants. And the most important, they have a growing lung, growing kidney, growing brain, growing hematology, growing bone marrow. So the all side effect will be more. The second point, the children are mostly suffering are three. There we divide clinically a pollutant into 3 groups: particles, silicon, boron, name anything. They are mechanical and allergic. Chemicals, you make sulfur dioxide, whatever it is, they make a biochemical damage. And finally, pollens or the weeds who are lower down, they make allergic reactions. Like, just like Punjab, in April, they will get high incidence of asthma, but nowhere in India because of the wheat thrashing. I will go to the third point. Particulate matter, 2.5 in children, airway has 3 parts: upper, middle, and lower. If the particle size is 5 to 10 micron, it is usually in the upper airway, dry cough. Unfortunately, that does not, very little. The most 2.5 that is between 2 to 5 micron, affects the middle airway, and that is why air pollution in children and adults will make more asthma, more COPD. That's the main area involved. And third, particle size less than 1 micron, they will produce chemical pneumonia. Again, that is also that much, not much common. Before we come, the fourth point is all systems are involved, as previously told by one of the senior scientists. Lungs to brain, hematology, we get more anemia, more leukocytosis and leukopenia. Then the most important is stunting and fat. The adolescents, you have a demographic profile for the last 15 years. They are now being stunted. The height is not that velocity, and they are obese, having hypertension and diabetes as a metabolic syndrome. Now we previously thought it is a Baker hypothesis. It can be your habitual problem. It can be sedentary habit. Now we believe air pollution has something role. Finally, immunomodulation, CD4 and CD8 counts vary, and that's why the infections and inflammation are much higher. And the final point, last but not the least, does air pollution change the DNA, the double helix? There can be a lot of statistics coming out. Can it change some genetics? So these are the difficulties we can. And finally, regarding the remedy that we'll all talk about, the only thing I want very much wish to know is, during the last COVID pandemic, since March last year to March this year, we and all the adult physicians are seeing less and less number of lung cases documented throughout India. Maybe that they are not coming up, but maybe the mask use, universal use of mask, universal social distancing, universal disinfectant use, which and the exercises and following the yoga and everything, maybe, we do not know, has probably changed the course of the lung diseases, probably reduced it. There can be studies on it. Regarding your point query, exclusively for children, there are, I think you know Dr. Parmesh, with whom I work. He was my thesis guide. Dr. H. Parmesh. He is the doyen of pediatric pulmonology from Bangalore. And he had the first publication I was a co-author, that was in 2014, regarding the air pollutions in Karnataka, not in Calcutta, and the effect in children as a follow-up study. And probably he's a part of the World Asthma WAO, and also the part of the air pollution central board in Delhi, pollution control board, as a pediatrician. He has many publications, and he has, I think, came out with a lot of publications in the pediatric age group. And he has also one published article, I think everyone have seen, regarding the police constables, traffic police constable working in Karnataka, published in 2015 or 16. So these are the issues that I remember. And regarding the studies, as Dr. Manoj Ranjan, right, there are very few doctors, clinicians who will be at present working as per knowledge in the study or epidemiological study on air pollution. For example, I just give an example to end the talk, is that I personally give postgraduate DNB and MD student 3 to 5 every year, and I gave them a dissertation. So it's not a thesis at all, but still they can run. But it's very difficult. We don't know where, even if we in the OPD want to work on the serum sulfur, whatever it is, there is no guide, there is no what you call plan. As Dr. Dey said, there is no systemic study, there is no systemic institute where we can send them to get the dissertation guide and through, so that if this is at least a few, so that we can have at least 3 years of studies, though very small, regarding the clinical effects of one of the pollutants in pediatric, that we can all offer, but we still have no idea where exactly we can go for help. Thank you.
Thank you so much, Dr. Ghosh, and a very rightly raised point about the gap in terms of these kind of institutes and these kind of statistics to kind of help further these studies. Dr. Dobe, ma'am, if I may invite you here to, you are heading a prestigious institute in West Bengal, and you talked about the GBD data. I wanted to know if you can throw some light on the status of health data from hospitals in West Bengal, or at least like the institute that you are with, or any other associated. If you can throw some light on that, I think that would be helpful, ma'am.
Gunjan, unfortunately, I do not have any access to, I'm not with the state government, so I do not have access to the state health data as such. So, but am I getting you with the sense that you want the state's profile of different types of illnesses, respiratory illnesses, or is it that you want to know?
Ma'am, I'm trying to understand that how good is the quality and the quantity of health data, and in terms of identifying the state's disease profile. Are there any gaps? If you think there are any gaps in terms of non-communicable diseases, especially with regards to air pollution.
Okay. See, there are, as to the best of my knowledge, and I would request Professor Sharma to supplement me if I am deficient in any part. To the best of my knowledge, whatever way diseases are reported, morbidities or mortalities, there is no way of understanding from the reporting whether it has been due to air pollution or not. So we are assuming that these are perhaps the diseases which have as one of the factors in their multifactorial causation, air pollution as well. So we do have reports of cataracts, we do have reports of lower respiratory tract infection. And how are they reported? One, they can be reported, mortalities definitely from death certificates. We have a lot to go, and that's not only in West Bengal. Everywhere, the reporting in death certificates, or are we following the ICD codes? That's a big, huge issue, and how they are reported, how they are recorded, that's leaves much to be desired still. But definitely we are trying. There are standard mechanisms, but as for every other practice, always it is not the ideal. The second thing is from the different secondary data that we have, there are hospital records, the hospital reports, we can derive some data, and there are some primary reports, primary data which comes from surveys, etc., etc. Now, from these hospital records and data, hospital records or data, now how much reliable are they? If that is a question which you are raising, then one is that diagnosis happens in the hospitals and reporting also happens in the hospitals. So, but reporting from the place where the diagnosis happens, it might be incomplete, might not be done in time. Right in the beginning, Chandnik was saying something regarding real-time data. How fast do we get this information? That might be lacking. There is a system of reporting non-communicable diseases via the IDSP forum. So there is a platform for doing that. There are various quality audits which are conducted on data in different types of diseases, and non-communicable diseases, of course, form a special focus. So we just cannot summarily say that all the data are to be questionable, but at the same time, the process of collecting and reporting data has undergone a lot of change from what was there, but still leaves much to be desired for. Because everybody, you have to also remember that everybody doesn't come to a public facility, not to a government facility. There is a lot of reporting, recording to be desired from the private facilities as well. And very few private doctors, private nursing homes do the reporting as desired in the standard protocol. So that's somewhere we need to put a lot of emphasis on. I think that's what I would like to say.
Right, ma'am. Thank you so much. And very rightly put, there is a lot of development, of course, in terms of the way it has been perceived and with the way the data is being collected in terms of quality and quantity. The profile of diseases, I think, over the decades has also changed and evolved. And Dr. Sharma, if I may invite you here, sir. I mean, I think I'd like you to address how air pollution now features in terms of understanding the profile of these diseases and trying to establish these interlinkages. Like Dr. Day earlier in the session rightly pointed out that anemia is also one of the factors which could be directly being driven by PM 2.5. So if there is a range of, I mean, and from a common understanding, a layperson understanding, you think that air pollution might be leading to asthma and leading to respiratory issues and maybe some cardiovascular issues, but not to the range of non-communicable diseases which you read about on a regular basis. So, sir, yeah, over to you from here.
Thank you, Gunjan, and good afternoon, everybody. But I would like you to be more precise in the question that you asked me so that I can answer exactly to your question. Can you repeat your question, please?
So my question is then, how much does air pollution feature as a risk factor in terms of understanding the disease profile in India, in kind of collecting the data, in being able to analyze it?
Got it. So for my friends who are not from the medical fraternity, and here I want to specifically mention first that most of the non-communicable diseases that we talk about, whether these are of respiratory system or any other system, if these are non-communicable, they are multifactorial in origin. Thereby, I mean that air pollution is not the only risk factor which is causing those diseases. Whether we are talking about COPD or we are talking about bronchial asthma or we are talking about mental health illnesses, whatever conditions. So this is one of the risk factors. Now, when it is one of the risk factors, there is a historical error that has been happening and we need to correct that. The knowledge of risk factor into pathogenesis of the disease is not something new. We have been seeing this development in last, I would say 70 to 80 years. For example, in COPD, we first said that COPD, the primary cause is tobacco smoking. That tobacco smoking is responsible for COPD. Then data came and there were studies which showed that in a particular study on a large sample, only 47% of the patients were smokers in the past. 53% patients did not have smoking as a history. So the question arose that if smoking is not the risk factor, what is it? And then we found that there were a sizable number of women in the rural area who suffered from COPD who were not smokers. So we thought, okay, it is the unclean fuel which is being used for cooking purposes that is causing COPD in them. That also could not complete the pie of 100%. So we thought, no, COPD cannot be explained only by tobacco smoke and the cooking fuel, unclean cooking fuel. Then came the issue, could it be dust? Could it be air pollution? And if it is particulate matter air pollution, then obviously the question shifts to chemical speciation. That which component of PM 2.5, what chemical composition is causing COPD. Now this I gave as an illustration. Now if you go for the list of the diseases on which data is being accumulated globally, it's exhaustive. We move from the respiratory system, we go to the cardiovascular system, we say angina pectoris, myocardial infarction, any acute cardiovascular event, air pollution is a risk factor. Diabetes mellitus, definitely air pollution is a risk factor. Cancers, particularly the cancers which are related to the respiratory system or brain or the blood circulation system, whether it is leukemia or any other malignancy, where air pollution is a risk factor. Come to pregnancy and related issues, pregnancy complications, low birth weight, premature delivery, and lack of mental growth in newborn children, including a disease called ADHD, that is attention deficit hyperactivity disorder. We know air pollution is a cause. Now here, as an epidemiologist, I want to mention there's a fallacy that is called epidemiological fallacy. We live in the same environment. All human beings are in the same environment, and therefore all diseases are in the same environment, and the air pollution is there for everybody. So mere presence of air pollution and mere presence of disease in the same community does not make a one-to-one causal relationship between the two. And that is where the knowledge gap is, that we need to address. That all these diseases that I listed, they are already established risk factors for them, which are documented in books, which are documented in different journals, and they are there. What is missing is that the data on air pollution, we are talking about data on health. Data on health is missing. I want to ask that today we are talking that we have got so much data on air pollution. Can you tell me what was the PM 2.5 level in Kolkata in 1960? Can you tell me what was the PM 2.5 level in Kolkata in 1975? We don't have that data. So how can we have that? How can we relate the data of health with that time's data of the pollution? So that means our understanding of developing this relationship between air pollution and health is very recent. And the gaps that are being pointed out, like Professor Sagnik said, Professor Madhumita said, definitely right, that we do not have data on these parameters on the diseases, because we never thought that this data is required for doing this kind of analysis. Now is the time when we can think of actually generating this data and putting it to use. Now, how do we do that? As Professor Gautam Ghosh also said, Professor Manas Ranjan Rai also said, we need to do longitudinal studies, we need to do cohort studies, we need to do time series analysis, absolutely fine. But when there is lack of capacity, when there is lack of skill, we do not have people, as rightly admitted, who can conduct these studies independently, or there are limited resources available. Can we really wait for this data to be generated? Is there an alternative? That is what I am coming to finally. That yes, there is an alternative. It's not that data is not being generated. It's not that all the data that is being generated in our health system is trash. Only question is putting the data in the right format, in the right frame. Let me illustrate the point. In a city, we have dispensaries run by central government health services. We have dispensaries which are run by respective municipal corporations, and we have a plethora of private practitioners who are seeing patients and treating. Let me go to the numbers. 47%, 60%, 61% of Calcutta's population is suffering some kind of a respiratory problem. Can it be more alarming than that? That 2/3 of your population means out of every 2 people are having some respiratory disease which is attributable to air pollution. That means these patients are going somewhere and getting treated. And where? 78% of India's health seekers actually go to the private sector and get their treatment from private practitioners or private hospitals. Where is contribution of this private sector in generating data for health? If I ask the private practitioners today that I want this data from you, how many doctors will be really gladly willing to give the data? That's the question. Why you always blame the government? Government is overworked, overrun, and is understaffed. So probably it does not have the means to generate and provide the data that is required. The data is existing in the private sector. It's a question of voluntary participation of the private sector in making this data available if the format is given. We need to address those issues. And the dispensaries, etc., that I was talking about, everyday patients are coming there. All that we need to do is create a simple format where we record the diagnosis. 99% of the doctors, I'm confident, in the country diagnose 99% of the conditions accurately. So quality of diagnosis is not the question. The problem is putting the diagnosis in writing, taking the pain of properly writing the diagnosis and transforming into a digital data is the real challenge. That is what is not happening, because patients are being treated. They are being given the medicine for the disease they are suffering from, and they're getting cured. They're not ending up in the hospital as in the ICU. That means the diagnosis is correct. But when you look at the paper, we do not find the diagnosis. So what do we need to do? We need to generate small forms, simple forms, simply to capture a little bit of information about the patient, its geo-coordinate, where is the patient located, where is his address, what is his diagnosis, 3 or 4 risk factors for the disease for which he is being treated, and what treatment has been given. And the environment in which he is living, that data is already there with Professor Sagni. It's a question of putting this simple data available without compromising the privacy and confidentiality of the patient by making this data unlinked and anonymous. I don't want to know the name of the patient. I don't want to know the address, exact address of the patient. If I know the age, if I know the gender, and I know the locality where the patient has come from. So a private practitioner has a catchment area of say 2,000 population. In that 2,000 population, if he sees 50 patients and I have the data of those 50 patients, I know in that locality, in that particular micro environment, 50 people are suffering from this disease. And that data can be interpolated, or rather modeled, with the air pollution data for the same level which Professor Sagnik showed as the ward level data. Now that is an excellent thing, that if we have PM 2.5 or other pollution parameters data available at the ward level, and we can generate health data at the ward level from these local dispensaries, private practitioners, and other point of care providers in the healthcare system in a city, it's very simple. That data need not be very elaborate, very scientifically proven, and with a plethora of laboratory diagnosis is not required, because majority of the conditions are simple treatable. It may be simple bronchial asthma, it could be allergy, it could be COPD, it could be allergic conjunctivitis, or it could be simple cases of people who are suffering from hypertension and having acute cardiovascular event, which are not very difficult to diagnose. And this forms the bulk of the problem. Only question is that we need to quantify that bulk and put into a digital form of data available. And the next point is that interoperability of the data has to be created. As Dr. Dipankar Shah said in the beginning, that we have apps for air quality data. Why can't we have app for the health data? Yes, we can generate similar platform where we can have simple availability of data, that today in colony A or in a residential area A, at the end of the day, how many people visited the respective clinics with a new problem of allergic conditions like allergic rhinitis or allergic conjunctivitis or any allergic disease which is directly related to air pollution. If that kind of data is made available with the help of volunteers and simple forms to be given to the government sector, which is where the doctor is overworked, we can generate a lot of data and real-time data. It may be delayed by 24 hours, it may be delayed by 48 hours, or it may be delayed by 72 hours, not more than that. Aarti is on picture, so that's an indication for me that I should stop. I'm crossing my time limit. So I'll definitely stop there. There was much more to say, but due to time constraint, it's better that I stop here and hand it over to Aarti. Thank you.
Thanks very much, Prof. And thanks for taking that cue. I mean, you said some very important things, which is why I thought rather than, with the little time that we have, maybe we do a rapid fire and get some of the other panelists say what they have to say, because, the way I'm the last 1 hour and so many of you all experts have said important things. But ultimately, my question is, when policy decisions are being made on air quality, is health data being paid heed to? Sorry if my question is really basic, but I'm also, I don't want to labor on it, but I know Dr. Chatterjee in the beginning said, don't create panic. And the thing is, whenever you put out health data which talks about how many people are dying or getting impacted, then it creates that panic in the public discourse. I do want to ask you, Dr. Sharma, once again, and if Shagnik, you can come, because you made some very important points on the GBD on top. The whole thing is that, all these data that are coming on health have some cohorts that have been done in the developed countries. And then, we have the ability to say that Indians breathe differently, and their biochemistry is different and their lungs are different, which might not be very true. But how do you triangulate all of that? How do you triangulate the regulatory decisions that have to be made for, say, West Bengal with respect to whether health data would be paid heed to or not? My question is to you, Shagnik, and to Dr. Sharma, and I'd like you both to respond.
Sagni goes first.
Okay, yeah, thanks. Yeah. No, I mean that the reason actually I raised those important questions, because I have been associated with GBD now for many years, and if you look at the counterfactual exposure, what GBD today considers, that is below 5 microgram per meter cube. Because in the developed countries, what happened is that not most, in fact, almost 95% of PM2.5 is anthropogenic particles, fossil fuel burning or something else. In India, that's not the case. So we cannot really consider 5 microgram per meter cube as a counterfactual. That is impossible to achieve. So what is the realistic counterfactual exposure level in India or in West Bengal or any state for that matter needs to be identified, number one. Number two is that when you talk about the chronic impact, as Professor Sharma also pointed out, that these response functions were generated based on the cohort studies in developed countries. We do not yet know whether or how representative they are for the Indian conditions. Obviously, we are using them because that's the best available tool, as I also pointed out in my video. But we should not just sit back and relax and say, okay, GBD is here and let's rely on that. We need to generate our own standards, own benchmark, own reference level. And as Professor Sharma pointed out, that can only happen when we have plethora of data pool coming in. Because if we today start generating that data, then 10 years down the line, we will be able to achieve that. So that's exactly my point, that we should not sit back and relax. Yeah.
Agree, which was also Dr. Manas Ranjan Ray's fundamental point about the brain drain, but that's our bigger issue to be dealt with on many fronts and not just on health sector, I presume. But Dr. Sharma, what do you say about this? Because the kind of things that you're saying to create, get the private sector to report on the data and all of that, those are enormous things to be done. They're simple, but even to put them out there in practice, there will be an enormous exercise to do that. In the end, if that data doesn't have to be used while prioritizing the alternatives for creating what are the 3 or 4 things to be done on air pollution management, then should we invest that much time and energy into that to create that understanding in the policymaker's mind, or should we at least go ahead and take some actions at the moment, because it feels that actions on the moment are at the level of speciation and source apportionment and figuring out what the problem is. And Dr. Madhumita showed that since 1995, we little bit know what the problem is.
Right. So the last thing first, definitely we need to take action. It's not that we will wait, as Sagnik was saying, that it will take 10 years to generate the data in the country and then draw some inference out of it. We need not wait for the 10 years. The existence of pollution is a problem. The existence of the different sources which are creating problem are now well recognized. So mitigating those sources or reducing the pollution is in the benefit of everybody, whether health or it is economic reason or for any reason. There's no doubt about that. That is absolutely fine. But to relate it to the health scenario and the aspect of improving the health of the people by reducing exposure to the polluted air can happen only when the interface between these two things is made more clear and understandable to the population. Now, I'm not saying that we need to have every private practitioner or every hospital on board to generate the data. We can set up representativeness. Representativeness, by that I mean that, as Sagnik said, that global burden of disease data, majority of the studies, exposure assessment has been done in developed countries. So in developing country, we do not have data. Let us set up one lab, you can say community-based lab in one area of Calcutta, and let all the clinics there generate the data in that particular area. Let's have a similar lab on a coastal city. Let's have a similar lab in an industrial township. Let's have a similar lab in a township which is close to the agricultural land. So that we have our own data for modeling. We need not depend on the data for modeling from the Western world or the developed country. So these kind of small studies taken up at few representative sites which represent the larger segment of the population, we can still have some meaningful data. We need not go for a very ambitious big plan for setting up 100 centers or 500 centers across the country and then try to do. No, that we are not matured enough to do that at this stage. Neither we have that kind of awareness in the community. So let us set up laboratories, community-based laboratories to generate this data. That's what I'm saying as a quick fix solution for the time being, and then it can be scaled up. If they are successful, we can scale it up to improve or increase the domain of the data that is available.
Okay, perfect. I think that's fairly realistic. That's also doable, and that will set some kind of a mechanism to start doing something, in the Indian context, and yet build on it from there. And the kind of idea that you gave to have a lab in an industrial township or a coastal city and then make it representative. I think this is the smallest thing maybe for policymakers to consider if they have to create air quality management plan, which is not just like a set of measures, but it's actually based in the rationale of public health. I know that time is inching close, but I wanted to check if Dr. Shaha, with all his wisdom, has any last words to say to the group, because sir, you have been involved, with your vision on the stratospheric vision, so to say. You have been involved in CPCB. You have seen how the debate has evolved. We are now talking about West Bengal. It's come to a point that in today's paper, there is an article in Times of India which says that political parties have considered environmental issues and air quality management to be included in the manifestos as West Bengal is going into elections. Couple of parties have done that. So the glass is half full. We have come some way, but we still have a long way to go. But I want to know from you, and I want to come back, that NCAP is a 5-year program. So if the state has to record some progress in NCAP, what do you think are priorities? I know I've asked this before, but I wanted to ask this to you as a wrap up.
Okay, thank you very much. It's a very good session. And particularly Sagnik has already told that we are going for the West Bengal board is going for the entire block to block study. And there will be installation of monitoring station at our block level, and including we will be having the macro and micro level monitoring station. And that day I was lucky to discuss the same with our Shagnik, that if these data can be linked with the health, and Dr. Sharma rightly told today, I do not know how the message went to you. It was my personal discussion with Professor Shagnik that until and unless we do something to protect the public health, we are not doing anything. So once we are having so much of vision of establishing so much of stations, until and unless we complete that circle with the health impact studies, we need to do something. And Dr. Sharma, really, that's why you are my brother. I know. I'm really happy, Arun, that our frequency matches. So that is the one thing. And I think if we are able to do it, we'll be doing good. And my question since beginning, why we can't have a dedicated health institute impact studies for India, exclusively dealing with the impact studies for public health. If that is being triggered and putting into action, we all would be grateful and helpful, because our main target is to protect public health. Thank you.
Thanks very much, Dr. Shah. We are also on
sorry,
top
I'll
of
interrupt.
the hour. Yes, sir. Yes, sir, please.
There is one Dr. Amit Sen here. Would you like, he may have something to say. He's a clinician and a friend of mine from my college days.
Sure,
so I can see.
Sure, Dr. Sen, please come in.
Amit, you're not audible clearly.
I will talk on a very light note, not the very serious discussions that we have had till now. Am I audible?
Yes, please go ahead.
Yes,
please go ahead.
Please go on.
Yeah. So, see, I think all in India, only one assembly election, that is Delhi election, had an issue on pollution. And now that we are in West Bengal having an election talking about Parivartan, nobody is talking about pollution. So unless whatever we try, unless the politicians come into play, we don't get anything out of anything. So that is one point. And while following the discussions, I heard that we shouldn't put fear into the people. We should put fear into the people. That is only one thing that can make them move, change their attitude to everything. As we have had with Corona, lockdown, people shut themselves up with the fear of death. And for this, I think, as we show on screens or like that, the smoking is injurious to health. We should also make this a national campaign sort of thing, that air pollution is injurious to health, and list what are the problems. Unless we do this, whatever data we generate, we just go on discussing it among ourselves. The fear of air pollution, and until it becomes a political issue, we won't be heading towards anything. Because out here, our say doesn't matter much unless the politicians pick it up. That is what I have to say. And it has been a wonderful discussion. I learned a lot. That is it. Thank you so much.
Thanks, Dr. Amit. And I will not get into the debate. If we were debating, I would invite Dr. Chatterjee to explain what he said. I do agree that we need a public campaign, and Indians are very good at getting scared and then doing whatever it takes to save their lives, which is why we all wore masks. But air pollution is such a long-term impact issue, and Corona was such a acute issue that it's hard to compare the two in my limited understanding. But this has been quite enlightening. And by the way, we did see that your chief minister went on an electric scooter. So so all I'm saying is that the messaging is linked to cleaner cities and clean transport. It's just that she did it as a protest to the rise in oil price against the center, and not really to promote electric transportation.
But that should have been more linked with the pollution part.
Right,
yes,
right. No link with pollution, just as a protest against the center. But it's on us to play these things a little bit. It's been a very interesting conversation. I thank you, all the panelists, for joining us this afternoon. I'm pretty aware that we've not had time to open the floor, but I imagine there aren't many questions in the chat. Otherwise, we would have picked those up. So thanks once again, all the panelists, for taking out your time. Thanks very much for panelists, Dr. Manas Ranjan Ray, Dr. Abhijit Chatterjee, and Dr. Madhumita, who didn't get a chance to come a second time round. But thanks everybody once again. Thank you.
Thanks.
Thank you.
Thank you very much. So much, everyone.
Thank you.
भाई डॉक्टर अरुण কোথায় একবার দেখি তো চেহারাটা দেখি এত সুন্দর আচ্ছা তো আরে সাগনিকের সঙ্গে সেদিন কথা হয়েছে আমার দেখো জিজ্ঞেস করো আজকে তুমি যা বললে সেই